All right, hello everyone, this is Dr. Pruett. Today we're going to be talking about best practices in cardiac arrest. This is something I think we do really well as an organization, but want to review the basics because it never hurts to go back and talk about the fundamentals. Some things we know for sure about cardiac arrest are that the basic life support skills that we have are the only proven life-saving interventions that we do. So for all you firefighters out there thinking it's the medic who's the smartest and most important one on scene, as much as I love our paramedics, it's actually the people doing the compressions and the people doing the ventilations that have the most proven benefit in obtaining a pulse on these pulseless patients. The first 10 minutes of any resuscitation are the most critical in any resuscitation and portend the best patient outcomes if we do a really good job in those first couple minutes. We know that early CPR and early defibrillation is the most important thing when we're talking about saving lives. If we look at what the American Heart Association is recommending as best practice, we know we want to minimize time off the chest, keep the compression rate between 100 and 120 per minute, the depth of 1.5 to 2 inches, allowing complete chest recoil and avoiding excessive ventilation. I think we do a really good job at all of these fundamentals. Our code stats help us as we review our time off the chest. The Lucas helps us with our compression rate and depth. And then now we have a ventilator to make sure we're doing ventilations correctly. Chest compressions are the most important thing we do in cardiac arrest. This is why we give pre-arrival instructions from the point of dispatch when the dispatchers recognize a cardiac arrest in the field. And the reason this is important is because that's what's helping perfuse blood and keep blood getting to the brain. So if you look at the top graph here, this is compressions and the perfusion pressure in the vessels while compressions are going on. And the bottom graph shows that if we continue compressions, we can continue a good pressure that's sending blood where it needs to go. But every time we stop compressions, that sharply drops off, and we have to start again from the beginning, trying to increase that pressure and getting it to where we want to be. So the less time we can spend off the chest, the better for perfusing those vital organs. We don't want to pause any longer than 10 seconds because that's detrimental to these patients. One of the things we purchased as an organization is the Lucas device. Crews have gotten very good with this. It allows us to do consistent rate and depth of our chest compressions. It is safe for transport. It allows providers on scene to multitask a little bit better. We know that it's just as good or better than manual CPR, and as it's becoming more prevalent in the community, it's getting more and more studies done, and it looks like the injury patterns are very similar to what happens during manual CPR as well. So we're seeing the same amount of rib fractures, the same amount of intrathoracic or liver injuries as you would with compressions that are done by hand. Again, like I said, we've gotten very good at this as an organization. I know crews practice together and have gotten pretty facile, and each station is a little bit different in how they employ it. But basically what you want to do is you're looking at putting this device onto the patient. During the first pulse check, you've already started someone immediately on the chest, right? Somebody's doing compressions. They're doing a good job. As the Lucas arrives on scene, during that first pulse check, you're going to get the patient into a position where you can get the backboard underneath them. Give yourself some room to work, and you lock the opposite side of the compressor to the back plate. And then whether it's during the second pulse check, or some crews are fast enough to do this during the first one, lock that device over the patient into place while continuing compressions, and then you adjust that suction cup on the patient's chest during the pulse check. Make sure it's in the right position, right over the middle, right over the sternum, not too low, not too high. And then you can hit the button to start compressions and initiate the device. All the operations are outlined in the SOG. This was published in May of 2019. It was SOG number 143. Remember to do your pulse check every 2 minutes. This is where we're going to evaluate whether or not we can defibrillate if it's a shockable rhythm or if we've gotten a ROSC. It's really helpful using the timer, dedicating someone on scene to keep track of this, because you can pre-charge the monitor in anticipation of needing to shock about 145, so that as soon as those hands come off the chest, we look at the monitor, and if we see a shockable rhythm, you can deliver that as fast as possible. We know that early defibrillation is key to getting a pulse back. The two types of rhythms that we shock are ventricular tachycardia and ventricular fibrillation. The paramedic on scene should be able to recognize these. If not, and it's a BLS engine crew there, you should be in AED mode, and you will get advised if it's a shockable rhythm. Sometimes patients have refractory ventricular fibrillation, and this is where we end up shocking multiple times, and every pulse check leads to a shock. If this is happening to you and you feel like that patient is one that really the heart is trying to start, you just can't quite get that area of the heart that is causing the fibrillation to come under control, you can consider changing the vector of your pads. Frequently, we place the pads in the kind of the right upper chest and then the left axillary area. And sometimes it's very effective to change to more of an anterior-posterior placement for your pads and changes the vector of the electricity that goes through the heart and capture more of the myocardium. Also, these refractory VFib patients are excellent ECMO candidates, so keep that in the back of your mind if this occurs on a scene. As we evaluate rhythm, I know that in our guidelines we have been taught for the longest time about H's and T's, and these are what's taught as the reversible causes of cardiac arrest. As we're learning more about cardiac arrest and as ultrasound is starting to evolve and our resuscitation strategies are starting to evolve, there's more emerging evidence in the literature of dividing PEA into two different types, the type with a narrow QRS and the type with a wide QRS. And what we're seeing is that if you have a narrow QRS that kind of looks like a normal heartbeat would on a monitor, this tends to go with shock states. So cardiac tamponade, tension pneumothorax, and pulmonary embolism all cause obstructive type shock. This can also, a narrow QRS can also be caused by cardiogenic shock as well. But this is a very different entity than the patients who have a wide QRS, which would suggest more of a conduction problem as opposed to a pump problem. So with a wide QRS, I tend to think more of severe hyperkalemia, severe acidosis, or maybe a sodium channel blocker overdose, like a TCA overdose or something along those lines, where it's actually conduction that's the problem and it's not a problem with blood flow itself. PEA is emerging more as a spectrum of disease, where over here on the right you can see that you have a patient with a narrow fast QRS. This is a patient who on the monitor it looks like maybe even a sinus tachycardia, but when you feel for a pulse you can't physically feel one. This might just be a patient who's extremely hypotensive and is not perfusing well, but that heart is still conducting normally and doing its best to try to perfuse everything. As you move along the spectrum towards a sicker and sicker patient, that QRS is going to start to slow down and widen out. And in the middle, this is what we call pseudo-PEA, or very profound shock, or end-stage hypotension. And as you progress to basically a wider, slower QRS that eventually progresses to asystole, this is true electromechanical dissociation and true pulseless rhythm. And this does not bode well for getting a ROSC. This is an interesting article I found. It was actually published in 1998 about how bad pulse checks are. Actually, this took a group of medical professionals. This included physicians and nurses and paramedics, and a little bit less than half of them were asked to find the pulse on a healthy adult awake male at his carotid. And almost half of them had a hard time finding it within 5 seconds. And this is on a perfectly healthy adult male. And now if you imagine them trying to find a pulse on a patient who is profoundly sick, maybe obese, in a out-of-hospital setting, you can imagine the sensitivity and specificity of finding a pulse goes way down. So the question is, with these PEA patients, are we just bad at finding pulses? And one of the things that helps us with that is ultrasound. And that's why we've deployed it in the field for cardiac arrest, because it actually physically gives us a picture of what's going on with the heart. It allows us to ask the question, is this heart actually squeezing? So maybe the patient actually has a pulse and their heart is beating, I just can't feel it. So ultrasound helps us see what's going on with the heart. One of the things that frequently comes up as a discussion point on cardiac arrest resuscitations is which medication should we give. We all are in a field where we want to do more and we want to do the best for our patient, and we think about all these things trying to reverse these causes. Narcan is a pretty frequent one with the opiate epidemic going on right now. But really, if you think about the indications for Narcan, if you have a patient who has had a respiratory arrest secondary to an opiate overdose, and they have already had this respiratory arrest to the point that their heart has stopped beating, giving Narcan is not going to restart the heart. And at this point, they're so profoundly sick that it's not going to reverse the respiratory arrest either. So what we do in this case, we don't give Narcan. It's not going to help. It's not going to restart the heart. We immediately start compressions, and then we just breathe for the patient. Because the minute that you have taken over respirations for that patient, you are now their respiratory drive, which the opiate overdose has depressed. Another frequent thing that comes up is the use of sodium bicarb. The only time this is really indicated is for your known hyperkalemic patients. These are usually your dialysis patients or your diabetics with renal failure. This drug can also help in TCA overdose to narrow the QRS. Those are really the only two indications for sodium bicarb. Studies have shown that if we're giving this routinely in cardiac arrest, it's associated with increased mortality and does not help improve outcomes for our patients. Another drug that's frequently asked about is D10. It's difficult to obtain an accurate blood sugar reading on cardiac arrest patients, and this is also not recommended in cardiac arrest and has been shown to increase mortality. That leaves us with epinephrine, which honestly in the literature right now has a huge question mark over its utility, but it's still recommended by the American Heart Association, and it's still in our ACLS algorithms. Everybody's talking about epinephrine and what's good about it and what's bad about it and what should we do with it. There's some good things we know about epinephrine is that it increases blood pressure, which increases diastolic pressure, which in turn increases blood flow to the coronary arteries. This is a good thing. It also makes the heart beat stronger and faster, which is a good thing when you're trying to restart the heart that might be in a shock state. Now, the consequences of epinephrine could be detrimental as well, though, because it does increase platelet activation. And if you have a patient who's arrested from a myocardial infarction, the last thing they need is more platelets coming to that area and making the clot bigger. Epinephrine also is such a potent vasoconstrictor that it clamps down the very small vessels in the body, which can have very devastating consequences for the smaller blood vessels in the brain. Not only that, but as epinephrine is forcing the heart to beat stronger and faster, it's also increasing the heart's oxygen demand, and it can preclude it to arrhythmias. So it's not a perfect drug, and it has some pretty profound consequences. Many of the questions that the literature is trying to answer right now is how often should we be giving it, how much should we be giving, what rhythm actually does best with epinephrine, which rhythm should not get epinephrine, and what is the best route. So here's just a quick review of some of the papers that are out there. Again, none of them are super conclusive, but it's good to know that people are having these conversations. One of the papers that asked how often should we be giving it was published in Resuscitation, and it looked at 20,000 patients who underwent cardiac arrest inside a hospital. And it evaluated the time between their first epinephrine dose and the endpoint of the resuscitation and looked at that over the total doses of epinephrine. And what they found is that the longer dosing intervals between epinephrine actually improve survival. And this is the paper that led us to increase our epinephrine timing from 3 to 5 minutes to giving it every 10 minutes. It was proven beneficial in patients. We know that it's good to give it early, but it seems to also be good to not be giving it as often. Here are two different papers. This was high-dose epinephrine in adult cardiac arrest and another look at high-dose epinephrine in pediatric cardiac arrest. Both papers came to the same conclusion that more is not always better. Interestingly, there was no difference between the two groups. One group got high-dose epinephrine and the other got the standard dose, and it did not seem to help any survival rates in cardiac arrest. This is a pretty interesting question as people are starting to ask which route is better to give epinephrine. Should we be using the IO, which is relatively quick and easy, or should we be giving epinephrine through an IV? And the literature is not quite clear on this subject yet. More and more papers are starting to come out examining this question, but here's one paper that was published in the Journal of Resuscitation, and it looked at over 35,000 out-of-hospital cardiac arrest patients and split them into groups that got either IO or IV epinephrine, and it turns out that the IO group had lower ROSC rates and lower survival to discharge than the IV group did. So it begs the question, is it actually better to give the ACLS medications through an IV rather than an IO? Still some unanswered questions there, but an interesting question nonetheless. And then finally, About a year and a half ago, this was the holy grail of epinephrine papers that everyone had been waiting for and hoping would answer all of our questions regarding epinephrine and cardiac arrest. This was called the Paramedic 2 trial and was published in the New England Journal of Medicine, and was actually one of the first randomized control trials of epinephrine use in cardiac arrest, and had thousands of patients. Ultimately, what it did show is that epinephrine, just like we thought, we knew it's really good at making the heart beat faster and stronger. So it tended to get more ROSC in patients that were undergoing cardiac arrest. The problem is, just like we reviewed the downsides of epi, even though it increased the likelihood of ROSC, it also increased the likelihood of neurological devastation, and it did not increase the number of neurologically intact survivors. So epi might restart the heart, but it doesn't necessarily bode well for the neurological outcome. So more and more discussions are being had about epinephrine. It'll be interesting to see where this goes in the future, but right now the things that we know for sure is that early epinephrine is beneficial for getting a ROSC. We know that it's not ideal for neurological outcomes. We know that higher doses are not better, and more epinephrine is associated with worse outcomes. Another thing we can do to help our patients as we're getting there on scene, we're immediately recognizing this arrest. We're starting compressions right away, getting set up to defibrillate as early as we can, and we're giving early epinephrine. You want to get that non-rebreather on so you can give some passive oxygenation until you get your compressions and the rest of your pit crew CPR going, and then establish a definitive airway. Again, another hot topic in the literature is ventilation rate and volumes and how very important these are to patient outcomes. If you're ventilating too fast or too much, as you increase the pressure and the volume in that chest, what that does is compress the smaller vessels, and that actually impedes the venous return to the heart. And the reason that's not great is because the heart is needing every ounce of blood that it can get to pump out to the rest of the body, and if you have too much pressure in the chest, it's not going to be able to fill in order to eject that blood. And so best practice is emerging that you want to use tidal volumes of about 500 milliliters per breath, which is really a pretty small squeeze on that big BVM that we're using. And then we want to keep the rate between 8 to 10 per minute. One of the things that we're doing to help us stay consistent with our ventilation rate and volumes is using a ventilator. This can actually set the volume that you're giving, and you can do that based on the patient's weight. And then you can also set the rate. It's really easy. I'm guilty of it too. When you're in a middle of a cardiac arrest trying to resuscitate a patient, there's a lot of adrenaline and energy going trying to help this patient. And it's very easy to ventilate too fast. And the more we learn about this, the more we realize how important it is to control that rate, because it's very important for patient outcome. We all know that end-tidal is incredibly important. This is something you want to get on early and get that early end-tidal number, because that's going to help with your ECMO decision. But you also want to keep it on throughout the resuscitation, because it's a good marker of how your resuscitation is going. If you see a spike in end-tidal, that might mean you're doing really great CPR, or it could indicate that a ROSC is coming eventually. Whereas if it's staying persistently low, this is a patient that probably won't end up doing as well. Now, if you do get a ROSC on scene, it's important to take a minute, slow down, check your own pulse, ask yourself what you could be doing next. So one of the first things you should do while you're still there on scene is get a 12 lead, evaluate where the problem is and what the problem is, see if you have a STEMI, and try to go from there. Make sure you have someone on scene who's starting a pressor. Whether your patient has a blood pressure right now or not, it's a good thing to get this going. These are super unstable patients. Once they've arrested once, you should anticipate that they're going to do it again. And if this is a patient who, say, is just in profound shock, you want to have a pressor ready that you can drip in, or either do a mini bolus push to help that blood pressure and keep that heart going. Whether it's Levophed or whether it's epinephrine, both of them should be fine. If available, you want to connect a ventilator. This will just, again, help keep consistency between those tidal volumes and the rate of ventilations. And now it's finally okay to check a blood glucose level and consider giving D10 if your patient needs it. Always on a cardiac arrest call, think about ECMO. Run your checklist for your inclusion criteria. If you have an adult that's 18 to 75, If they received bystander CPR and had an initial end-tidal greater than 10 and an initial rhythm anything but asystole, this is likely a candidate as long as they don't have any severe underlying comorbid conditions and it's not a respiratory arrest, such as an overdose or a strangulation or a hanging. Evaluate your ability to get to the hospital within 35 minutes of collapse and have a low threshold to call ECMO 1 to the scene if you need them. If you find yourself on the scene where you've been working for 30 or 40 minutes and you haven't been able to get a ROSC and it's time to start considering a call for termination of resuscitation, when you do make the MSUP call, here's just a couple hints and tips that might make it a little bit easier. This is the things that the physician on the other end of the line is listening for. So if you can tell them up front that you're calling for termination, they always like to know the age of the patient and a little bit of underlying history if it's available. The first question is always the initial rhythm and the initial end-tidal. This kind of paints a picture. If you start with a patient in asystole with an end-tidal of 10, they're going to have a little bit different reaction than they would if you had a patient with VFib that you shocked, say, 6 times with an end-tidal of 40, right? So initial rhythm, end-tidal are important. Talk about the interventions that you did over the last 30 minutes, whether it was solely epinephrine or whether you had a couple shocks in there, whether you've given an antiarrhythmic, and how long the resuscitation has gone on. And then finally close with where you're currently at with the rhythm and what your end-tidal is. And it paints, all of those things will paint a pretty clear picture for the physician on the other end of the line if they're thinking about actually terminating or maybe have some advice for further things that you can do to help. This is a new reminder this year. There's a new guideline out that you no longer have to call an MSUP if you've had a patient who was initially in asystole and has remained in asystole for 20 minutes without a rhythm change. You can go ahead and terminate without having to call a physician. One of the things that I found really difficult early on in my medical career was how to approach families who've just lost a loved one. These are some of the tips that I found helpful as I was learning from people ahead of me who had done it and were teaching me how to talk to family about these things. Number one is you always want to make sure that you're safe. You never know how a family's going to react to this devastating news, and some people react in anger, so you want to make sure that you're safe. As early as you can, you want to set the stage and explain in pretty factual terms what's going on with the patient, the fact that they're not breathing and their heart's not beating. Try to use pretty simple language that's clear for everybody to understand. You don't need to use medical language. People aren't going to understand what you're saying. I always try to assure people that what we're doing is the same thing that would be happening in the hospital. We've essentially just brought the hospital to the patient, and this is going to give them their best chance at recovery. I try to check in with them every once in a while as to how things are going. If you need to, you can explain the ultrasound or the ventilator. And then at the end, if you got a pulse back, that's pretty self-explanatory, and you can talk about the fact that you're going to the hospital and the heart started beating again. But if you end up not getting a pulse back and having to deliver bad news, I try to be as clear and compassionate as possible, but you want to make sure that you state the facts. So I tend to say something like, we did everything we could, the crew did a great job, but despite our best efforts, the patient died. It's important to use the word dead or died instead of euphemisms, because like in a better place or other things like that might be easily misinterpreted or misunderstood by families. I tend to kind of take a pause, let the information digest, and then hang around for any questions or things that might be voiced after delivering that news. And then when it's appropriate, I kind of talk about what to expect next, whether it's police on scene or the arrival of the medical investigator, and kind of set the stage for where things are going to go from here. Finally, in conclusion, when talking about cardiac arrest, we know that basic life support is the most important thing we can do to help our patients. So we want really good compressions, really early, excellent CPR, early epinephrine, early defibrillation, and really doing our best to control the ventilation rate and depth. And that's all I have. If you have any questions, please contact the 7-8.